Hi, good morning, good afternoon, everyone, and welcome to today's webinar. Next slide, please. Again, welcome to our webinar for today, Peer Support Approaches for Healthcare Providers, Innovation, Engagement, and Connection to Enhance Wellness. This is session 2, 1-2-1-2 care, colleagues aligning to respond with empathy. Next slide, please. This webinar is sponsored by the Northeast and Caribbean Mental Health Technology Transfer Center, or MHTTC. We're housed at Rutgers in the School of Health Professions in the Department of Psychiatric Rehabilitation and Counseling Professions. My name is Kathy, and I'm the project coordinator of this center. I'll be hosting this webinar today. Next slide, please. And if you're interested in staying up to date with the events and products the Northeast and Caribbean MHTTC is providing, we ask that you please sign up to receive our email communications. You can sign up at the bit.ly link provided on the screen, and I will also share this in the chat box and in a follow-up email. Next slide, please. Following the webinar, you'll be asked to complete a brief survey. We value this feedback and use it to improve our activities and inform our future activities. The surveys are also important because our continued funding is linked to the completion of these surveys, so we thank you in advance for your feedback. Next slide, please. We also want to let you know that this webinar is being recorded and will be posted on our website along with the presenter PowerPoint slides in the next few days. Next slide. This presentation was prepared for the Northeast and Caribbean Mental Health Technology Transfer Center under a cooperative agreement from the Substance Abuse and Mental Health Services Administration, or SAMHSA. All material appearing in this presentation, except that taken directly from copyrighted sources, is in the public domain and may be reproduced or copied without permission from SAMHSA or the authors. Citation of the source is appreciated. Do not reproduce or distribute this presentation for a fee without specific written authorization from the Northeast and Caribbean Mental Health Technology Transfer Center. At the time of this presentation, Miriam Delphin-Brittman served as Assistant Secretary for the Mental Health and Substance Use at SAMHSA. The opinions expressed herein are the views of the speakers and do not reflect the official position of the Department of Health and Human Services, or SAMHSA. No official support or endorsement of DHHS, SAMHSA for the opinions described in this presentation is intended or should be inferred. Next slide, please. We encourage you to interact with our presenters during our webinar by using the chat feature. Please post any comments or questions you have in the chat, and I will collect your questions as we go and ask them of the presenter during the Q&A time towards the end of the presentation. During the webinar, our presenter may pose questions to you, so please use the chat feature to answer them. Next slide. The MHTTC network uses affirming, respectful, and recovery-oriented language in all activities. This includes language that is strength-based and hopeful, language that is inclusive and accepting of diverse cultures, genders, perspectives, and experiences, language that is healing-centered and trauma-responsive, language that invites individuals to participate in their own recovery journey, person-first language and free of labels, language that is non-judgmental and avoids assumptions, and language that is respectful, clear, and understandable and consistent with our actions, policies, and products. Please. Let's begin our webinar. We have Dr. Chantel Brazo, Dr. Ping-Shin Chen, Dr. Manasa Ayala, and Dr. Peggy Swarbrick with us. Dr. Brazo has over 25 years of experience in the field of health professional well-being. She has taught about well-being and burnout, conducted local and national survey-based studies on medical student, faculty, and physician well-being, and presented at national and international venues on these topics. As the inaugural Chief Wellness Officer at Rutgers Biomedical and Health Sciences, she works with school, university, and hospital leadership teams to explore and lead the development and implementation of wellness initiatives for faculty and healthcare providers. Dr. Chen is an experienced mixed methods researcher with extensive experience in intervention studies, community service learning programs, quality assurance, and quality improvement projects and clinical trials. Dr. Chen is proficient in building and managing secure online surveys and databases and using specialized statistical software packages for data analysis. She has provided quantitative and qualitative analysis and evaluations of several surveys on faculty and health professional well-being. Dr. Ayala completed a fellowship in medical education and has formal training in qualitative methodology and experience conducting large survey research. Her work exploring bullying in residency training was published in the Journal of the American Medical Association in 2019. She has experience in physician wellness interventions spanning the learning continuum from undergraduate medical education to faculty wellness, and currently serves as faculty vitality champion for the Department of Medicine and chair for the Department of Medicine Wellness Committee. Additionally, she has personal experience with engaging in informal peer support through a texting platform. And Dr. Swarbrick has worked for over 35 years in a variety of healthcare settings, designing and evaluating innovative peer-delivered models and training programs that promote wellness and resilience. She has created an 8-dimensional wellness model adopted by the behavioral healthcare agencies and state authorities across the country. In addition, she has developed a wellness coaching model and wellness self-care programs for a variety of populations, including health professionals. Dr. Swarbrick has published extensively on a wide range of topics, including health disparities, the wellness model, and health promotion approaches. So again, I want to welcome everyone here. I want to welcome our presenters, and I'll turn it over to them.
Thank you. Thank you very much. So we'll be talking with you today about one of our programs that we called One-to-One to Care, Colleagues Aligning to Respond with Empathy. Next slide. And once again, our team members are listed here. Next slide. And just to set the stage and talk a little bit about the background and the needs that led us to develop this program, I wanted to take a few minutes to go over some responses that are experienced really by everybody to disasters and pandemic, such as COVID-19. And the most common, frequent response is actually resilience. And so it's important to remember that, responses that people have reflect a tremendous amount of resilience, creativity, and problem solving, and it is the most frequent response. In addition, and along with the response of resilience, people can experience distress, particularly sleep distress, sleep disorders, or difficulty sleeping, very common distress, but also a decreased sense of safety, physical symptoms, some irritability or some distractedness, feeling of isolation. And people can go back and forth between being resilient and having distress, and actually expressing both. And also very common is a change in health risk behaviors, like an increase in alcohol consumption, tobacco, or substance consumptions, as well as some strain in the family, even some conflicts. And along the continuum of behavioral responses, one can actually go all the way to formal psychiatric distress or disorders like depression or PTSD or complex grief. And so everybody experiences this as well as the healthcare providers that we're discussing today. So next slide. So the need for our peer support program. Well, the emotional impact of COVID-19, as just described. But it's important to remember that healthcare professionals were experiencing burnout even before the pandemic. So adding that to the emotional impact and the additional demands on clinical care to fulfill the university missions, the increased demands of all faculty, all clinicians, really the whole health professional team, really brought us to think, what can we do to support our faculty, to support our physicians? And one important piece is that surveys, data, research has shown physicians tend to be very self-reliant individuals, but respond well to peers. So sometimes there may be reluctance to seek help from formal mental health support, but the responsiveness to peers is an important a strength that needs to be harnessed to really able to support our healthcare providers and our physicians. Next slide. And this is a definition of burnout. It's a combination, and it can be any one of those symptoms or all of those symptoms of emotional exhaustion, depersonalization, meaning that you're not treating people, you're treating more like the diseases that people have, and a decreased sense of personal accomplishment. So in summary, lost energy, lost enthusiasm, and lost confidence. Next slide. So we really wanted, in response to all of this need, develop an evidence-based worksite program for physicians to really support their well-being and their ability to provide the care to all the patients, especially during this crisis, and that patient-centered care can be done. We were also including in this all the medical school faculty, who also have research and education missions, and we wanted to be supportive to all of this. We wanted to develop a sense of community within our workplace culture through this peer support program, improve well-being, and those who were being supported by the peer supporters, and utilize the results and sort of provide a proof of concept so that we can obtain future funding to extend this program beyond the physicians with whom we started, but to go to other schools for other health professions that are part of our university. So we wanted to start this as a pilot and really extend it to all health professional team members. Next slide. So in creating a culture of peer support, it's important to remember that even short connections can be very powerful, especially in periods of crisis where people are going from, action to action, thing to thing, one thing after another. Even short connections can be very powerful. We wanted to create opportunities where people can share and support each other and move people from the idea that it's all on their shoulders, that we need to look at peer support in a systems way, much like we used to view medical errors as the result of an individual making a mistake. In the last 20 years, we've really moved to look at medical errors as a systems problem, looking at what in the system is maybe poorly designed that predisposes individuals to make errors, and that's the outcome of a mistake or a medical error is frequently the result of multiple places where a change in the system could make a difference. So you don't blame individuals, but you support the individuals in making changes in the system. So very much like that, we wanted to do the same in this peer support, because physicians and healthcare providers have a tendency to really carry the burden on their shoulders, really take on to themselves. And we wanted to move from that individuality of accepting all the strain and the stress to a culture where you support each other. Next slide. And so here was our program, One-to-One to Care, colleagues aligning to respond with empathy. And so the way we approached it, we had one or two faculty or physicians per medical school department throughout 2 medical schools. And we trained them in peer support techniques so that they could provide support on site at work, especially after emotionally difficult situations. And this program was approved for continuing medical education, or CME. Next slide. And so we started by going to the different chairs of the departments, asking for nominations, and inviting the nominees to become peer supporters. And those who responded that they were interested in becoming a peer supporter, then we trained in peer support techniques. There were 31 faculty physicians who accepted the invitation. And we made sure to train them both in situations where they would provide on-the-spot support or even scheduled support. But realizing that in the midst of COVID-19, the on-the-spot, on-site support might be the one that's most frequently used, especially after challenging work situations that are bound to happen in this type of crisis. And after our peer supporters were trained, we arranged for monthly meetings so that they can share, without, of course, mentioning names, but share the types of situations in which they were called to provide peer support, so that to make sort of a learning community for other peer supporters to learn from the experience, and also for the peer supporters themselves to support each other. Because as recipients of difficulties from other people, they themselves are carrying a burden. And we provide CME for those monthly meetings, as well as for the initial training for the peer supporters. Next slide.
So part of how we started out was with the training, and we're just going to give you a little bit of an overview of some of the topics, areas of the training. We did it, organized it with just introductions, getting people to know each other, and then really similar to what we just mentioned before, really understand the mental health consequences of natural disasters and the whole idea of burnout. So we highlighted, again, the piece that resilience is really strong there, but to be mindful of some of the health risks, some of the distress, and some of the other kind of mental health or challenges that people may encounter in terms of depression, anxiety, grief, things that people may go through. So just understanding that picture of burnout, and particularly some of those risk factors. So as they're doing this work, they can pay attention to those areas of risk, but also focus in on those areas of strengths to build the resilience. So we highlighted it, and I'll go over a little bit more in a minute, some of the roles and the competencies and boundaries, some basics and tenets of peer support, some of the peer support process, as well as try to highlight, when is the point where you start to reach out and help link and support people to find other types of resources that might help if something's a little bit more difficult. And as part of any training, it was some information sharing, but it was a real focus on practice. There was a lot of role play, and we'll share an example of that in a minute, of really giving opportunity to practice the competency skills and get feedback, and also get real life situations, as well as be able to get feedback for one another, and also just that practice opportunity. So we, again, use part of the script that we, the flow that we have developed for this model is, understanding particularly the peer support. And that was really an important piece, to understand that we're colleagues and we're peers in that way. But there are competencies and roles as a peer supporter that go beyond just being a fellow physician or faculty researcher. The importance of orienting people and opening up in an inviting way to, if you're going to meet someone on the spot, or if there is a planned session with that encounter that someone schedules, to really use a script that they develop that they can do in a natural way themselves, but that does clarify the role. A big piece of the training, and particularly the practice and the feedback and support we gave in the training, was really understanding that deep listening and reflecting and making that connection, as well as really helping to listen and help the person to reframe the situation, to help them gain perspective, to focus on their resilience and some of the coping skills. And then in any sessions, it's being able to close it, summarize, and then link to resources as needed, as well as perhaps for sometimes following up. And by illustration, we wanted to highlight, we have a flow. We'll show you the checklist is here. And this checklist was really some of the competencies. We went over the content, but we used this practice, this checklist, which was really helpful in the training. and really wanted to highlight, the elements of it that really helped to reinforce for the peer supporters the methodology they used. But also what we were very excited to do was to be able to create the flow onto the badge that could be attached to the badge that would show someone as a peer supporter, but it also gave those cues in the prompts, which people found was very helpful, just from, remembering what is the skill and then actually using it. So now we're able to reinforce it by having this, onto that, something that they can attach to their badge to remember and remind them in that role. And again, also the peer supporter, it puts it out there that they're there, so people would know who they are and can reach out if they see that on their badge. So we do the training, and part of the training again is really in the practice. A lot of it is just practicing being present, helping to understand the impact of distractions. And we'll talk a little bit about some of the specific distractions that often can come about, especially listening blocks, helping to lead from a strength-based focus, again, to help build that resilience and tap into that resilience. And then another piece of this that's so essential to the peer support model is learning when and where and how to share snippets of your own experience that might be relevant to help with the connection, or might help with some of the reframing, or might help with reminding people of some of their coping and resiliency factors. So again, learning that art of sharing things in very small bite-sized chunks that can help facilitate that in the other person's thinking about what's really happening from them, by sharing that connection, using a lot of listening skills. And I think that was a big, very, very strong pieces, was just, though everyone has been trained in this, but it's training it to move it again from the title of one-to-one care with that empathy, to use that empathy and sharing in a way and responding in a way and connecting in a way that really facilitates that empathy. So a big piece that really was, I was surprised how favorite this was. This was a very, very popular activity, and something we go back to in our peer-to-peer support sessions is reminding people of the blocks to listening. So this was a really, really important piece, though all of the pieces were to really be able to remember that we all come in with blocks. On the one hand, we're coming in to share our relevance experience, so we're preparing to that, but then becomes can you identify, but how does identifying then move into a way that may interfere you really listening to that person's story, to that person's situation, and you start to interject your own agenda or your own experiences too much, that is that block to really listening to that person's content, feeling, and meaning of what their experience is. So learning again how to not to rehearse, which can be a challenging one as well. The many, many distractions which are always in people's way. The comparing can come up, because a big piece of this whole model as a peer-to-peer is not to advise, not to fix, not to get to the root cause of the problem. It's to really listen to the person and suspend the answer that we think we have. So again, this listening block exercise was really, really important, as much of the training and the follow-up was. So this was just a little bit of a snapshot of some of the training content and process that we use to help prepare. And now we go back to these competencies in our sessions, in addition to doing check-ins, do some refreshers on these topics as we go on each month.
Thank you. I was also so impressed at the insight that people had as they reflected on their own listening blocks. They would really think about it and say, yeah, in my case, advising really interferes. And that was a common one where they're, as healthcare providers, you're trained to fix problems, find solutions, diagnosis, and fix. And so that was one major, going right away to the advice instead of really stopping and listening. That was a very common one that we heard our participants, our peer supporter trainees say. So this is an example of a role play that we developed. This was a role play of a situation that would happen at the work site. And what we did during the training, which was a virtual training, we had people form trios. One person was going to be a peer supporter, the other one, the peer who is being supported, and the third person, the observer. And each trio was put in a breakout room. Before going to the breakout room, we asked the peer, the would-be peer, to select one of two scenarios. One scenario was a clinical one, and the second scenario was a more of a faculty type of scenario, because again, a lot of our physicians all do research, or many do research, and many and all really teach. So this example here was, you see a colleague experiencing a hectic clinical day with multiple emergencies and bad patient outcomes. Example, several deaths during COVID-19, or a long-term patient who dies. The second one is, you witness a colleague receiving yet again news that a grant has not been funded. So the peer had to select one of the two scenarios. And when we instructed the trio before they went to their breakout room to practice orienting. So the peer supporter was to practice, introducing himself or herself, orienting the peer to the role, and then going through the peer support skills according to the flow or the checklist that we had shared before. We asked the peer to respond as you would if you were in that situation. And it was amazing. They knew exactly how to respond, because all of them had really been exposed to something like this. And then the observer was going to make notes using the checklist skills. We gave them 10 minutes to go into the breakout room, and then came back to the general room. After after they came back, then we did a debrief. The way that we conducted the debrief, we first asked the peer supporter to state how well he or she thought they did, what they think they did well, and what they think they may have done differently, to really get them to think or reflect on the interaction that had happened. And I have to say that many of the peer supporters, they tended to be pretty hard on themselves, actually, more thinking about what they had not done as well. But when we then turned to the peer, the one who had been supported, and we said, so how did you feel being supported by your colleague? The peers were actually a lot more positive, and gave a lot of feedback to the peer supporter. Yeah, you weren't that actually felt really supported by you. You're criticizing yourself, but this was a very supportive encounter. And it was actually amazing that the peers would tell us, even in this role play, because they were interjecting some of themselves and some of their own experiences within the role play, they actually felt better having gone through the role play. So that was really interesting. So the peers gave feedback to the peer supporter, emphasizing, what had been done very well, and also things that could have been done differently. And then the observer finalizing the debrief would then look over the checklist skills and make note of what they witnessed and what they did not witness from the checklist skill, so that people can reframe and say, okay, next time I will make sure that I incorporate more of this or that from the checklist. We had 2 role plays for each 2-hour-long training that we did. And we also utilized this same model of role play in our monthly meetings. So in future monthly meetings, we may realize that people may tell us, oh, I wish I knew a little bit better how to reframe. So we would do a role play in those monthly meetings where we focused on the reframing aspect of the encounter, so that they can tweak that skill. Next slide. So once we trained all of our peer supporters, we wanted to announce the program. We had announcements through the email listservs. We have some faculty wellness champions, representatives of each department. So Dr. Ayala is a champion in one of our departments at one of our 2 schools. And so we asked the champions to also talk about the peer supporter program. We made presentations before our chairs, before executive leadership. And we actually presented the peer supporters in the listservs and the newsletters. And if you can show the next slide, we explained what the program is about. And then following this explanation, we actually had each peer supporter with a nice professional picture and and their name and the department that they represent, so that people could recognize them, in addition to the tag that Dr. Swarbrick mentioned before. Next slide.
As we mentioned before, we recruited 31 peer supporters. Looking at the general demographics of the peer supporters, 45% were white, 21% Asian, 10% Black, and 3% Hispanic. This is similar to the school's composition. Our peer supporters reflect the diverse of the faculty at our institution. About 1/5 did not disclose their race ethnicity. Next slide, please. The majority identified as women, 30% identified as men. Next slide, please. 1/3 of the peer supporters were at the assistant professor level. 1/3 were associate professor, and 1/3 were professors. This is good representation of peer supporters across levels of experience.
Sorry about that.
It's the number 21.
Sorry.
Thank you. As I mentioned, this is good representation of our peer supporters across levels of experience. Next slide, please. We surveyed the peer supporters at the end of the 1-to-1 care program with a 52% response rate. 75% of the peer supporters reported that it was very or completely true that the training helped them feel prepared to address the needs of colleagues. About half of them said that it was very or completely true that they felt able to offer important support to enhance fellow colleagues' well-being. And almost all of them reported very or completely true that during peer support meetings, they were provided adequate support to perform their role as a peer supporter. Next slide, please.
So during the first 6 months, some information that we gathered around people that were supported, there were 32, and this is of things that were reported to us. There could have been more that were there, but there was 32 reported counters of peer support where peer support skills were used, and all but 2 were informal or on the spot ones during that period of time. And most of the encounters were with faculty colleagues. And so there's a breakdown there related to some of the others types of encounters they use that peer support skills with a medical graduate school student, another member of the team, or even people that they're serving, the patients that might be serving. And among this, some of the common topics that people were experiencing, that people that presented were just in altercations, things that had happened, not physical, but just things that were challenging situations, interpersonal conflicts in nature, a lot about the frustrations of the work, some of the things that were mentioned of the reasons why even this whole program was developed, different challenging patient outcomes that they had experienced, as well as just their own personal issues, their own health affecting work, as well as racially based traumatic encounters and big, very generally, but the burnout signs, things, people's feeling of burnout and some of the factors related to burnout.
So recurrent themes and focus groups included some lessons learned. So the importance of active listening, knowing that that sort of temptation to fix things, as Dr. Brazo was talking about in terms of kind of the healthcare worker identity, can be difficult to resist. The importance of reframing and thinking about other perspectives, reaching out to people who don't look like themselves and getting that additional, vantage point. And then, asking the person about their own way of coping was actually not used as much. Next slide. Some representative quotes that really kind of show these different themes. And I will go through them, but I think the thing to really focus here is that faculty are used to talking with patients, and learning how to reframe some of these skills and talking with peers, maybe not something we're trained to do, came up a lot, as well as sort of that thinking about a new application of a known skill set. So one representative quote, a participant said, "I think what was really great was the skill set that we now had access to, that it was just making us aware of different ways to reframe things." Another said, "For me, the most challenging was jumping to a quick fix, not listening. And through this peer support training, I've now learned to listen more and also about reframing. And I think that's been really helpful for me." And another participant said, "It is meaningful to feel like there's a chance to help in a different way that we are not used to, in more of an official kind of capacity, and more just that feeling that we may be able to contribute in a different way." So this increase in awareness of how to reframe in the context of peer support really comes through in these representative quotes. Next slide. Additionally, other quotes, I think it comes in handy with all levels of people that we work with. I think that's part of the grooming that I wanted for myself, that I think it actually helped tremendously in the interpersonal communication skills, how to communicate better in a more supportive way. And people just stated that they were glad that we did this when you had a chance to talk to someone about it. So again, thinking about how a skill set might be siloed, and realizing that actually many of our skill sets apply across disciplines, across people, and are much broader than are expected, and are also very bi-directional, and helping with interpersonal skills. And again, that reframing comes up again here. Next slide.
So we've described the program, and we're hoping that you'll put some things into the chat as you have specific questions, but we just kind of wanted to give you a framework to think about, just what an important, amazing resource this can be if you're thinking about this for yourself, or you're thinking about how to put this into play in your own work, whatever level of healthcare you're working in, where this might fit beyond having, whether you're working with physicians, working with other kind of health providers, or other individuals that could really benefit. So that's what we wanted to kind of highlight a few things, and then we'll be coming to some questions. Really thinking about the target population and their need and why. So I think that one of the successes of this was really knowing clearly who this was training, who the peer supporters were going to be helping. It was very, very important, the who, the why, and then some of the things about the how will highlight as some of the other aspects. But again, really being very clear about that. And then also really getting the feedback as you think those through, and gathering feedback from people to understand, and having their involvement as well. The leadership and support, or departmental support, so having that really administrative factor is also a very essential component of this. That was a strong piece in this. And, as Dr. Brazo, she has a very strong leadership in this area, and really being able to kind of communicate that with other types of leadership that needed to be supportive, and having those kind of connections, and being able to really work with all the different departments and there's all different players that need to be talked to, understand, get their feedback, really being mindful of all those things, rather than just coming in and say, well, we're going to do this. You can't do it in that way. It has to be really building from the ground up and really strategically to let everybody know and having that support. It's peer support, but the support, there's lots of layers of support that are needed to make this kind of a program a success. And really think through, and again, we were just challenged in some of this way where we had to kind of come thinking through even more. You know, typically we would have been doing training in person, but we were doing it virtually. So we needed to think through the different ways we can do that training in a way that could be have a similar experience in that training in a virtual mode that we would have in a if we were face to face, but for all facets of even delivering this, thinking through the supports as well as the other resources, human resources, administrative supports, how to adapt and adjust to some of the technology, really are important things that really were very important to plan through. And as you think through your own, perhaps, okay, we'd like to do this, these are some of the factors to be thinking through. The marketing strategies and the marketing tools that were used. This is another one you want to be thinking about. How are you going to best recruit the people who can come to the training, be in the training, and then how do we let the word out there to know about this being a resource that is available to people. So it's thinking through the populations that you're thinking about doing this with, and being able to figure methodologies of sharing this information in different ways, not only just emails or posting things around. There's other ways of that you want to be thinking about to let the word out, and also be able to, in the training of the peer supporters, making sure that they knew that they are part of the marketing of letting people know and understanding in that peer supporter role. You're going to help with some of the marketing strategies as well to let yourself know that you are a peer supporter and being mindful of that. And a big one, which we all learned probably for the last almost 2 years or close to 2 years, is all of the obstacles that we can never know all of the obstacles or challenges that are out there, but to start to map some of them out and have game plans, as well as be attentive to they're going to be there, but they don't need to impede the progress. Sometimes they actually even bring a new opportunity to do something new in an innovative way, or maybe to change the approach that we were doing. So being more mindful of those obstacles and start to just plan for them and know that they're going to happen and be okay with that, rather than getting too upset and too derailed when they do come about. Other types of practical strategies that we think that is important. And I think, as you saw, we have some modest data on this, and it's really the data, like when you hear some of the experiences, that just speaks to your heart of like the benefit that this has for people. And even as we've gathering even more, there's just such an impact. But gathering some data strategically, not overwhelming with data, find some modest things that you could start to understand, gathering some information, tracking it, and sharing it regularly is an important piece too, which again, every follow-up meeting, we shared with the peer supporters the data that how many were being done, what was happening. They were getting that feedback back to them, which I really think was really helpful for the ongoing training and mentoring, supporting of the peer supporters, as well as showing some of the benefits. And it also helped us in terms of us planning those monthly sessions with how to adapt training as well. But I think also from the larger piece, if you want to show some impact and efficacy, gathering some of this data will help perhaps bring in additional resources and funding to be able to bring it a little bit more to scale. And then again, just having the communications with all types of stakeholders about the progresses and challenges, and particularly when there's a challenge, and being able to know that leadership support that needs to be reached out to and connected to be able to know who and when and how to kind of overcome it, or maybe change the tactic. We're doing it currently with residents, which we need to do a little bit differently. And we're learning a lot more about some different things that need to happen in different ways, but it's that open communication with the key players involved in residency that is very important. So we definitely want to hear your questions or feedback to us that, we can take now. If anyone wants to, if there's any in the chat, the chat function, or we want to see if anybody opens up to kind of ask a question.
Thank you, Dr. Swarbrick. So in the chat, we do see someone that shared that peer support for peer supporters is something that they thought would be supportive regarding the IRTS, as well as possibly all peer supporters.
Yeah. So people who are already in peer supporter roles, formally having this kind of additional training and support they're suggesting might be helpful.
Yes. And I have a couple of questions that came to mind as well. Oh, someone said, is there a way we can receive a copy of the slides from today's presentation? Yes, the presenter slides will be posted on our website along with the recording within 7 days of this webinar. You mentioned that the peer support process and providers, they felt more comfortable sharing with other providers. Can you maybe speak to how this has helped maybe reduce or address the stigma of people needing outside support, or was it more within their own network of peers that it seemed was able to impact the stigma?
I'm not sure the question. So is the question that that we had the sense that because it was someone who was another fellow physician and they could talk to them in this peer support way, that were they asking, do we think that's why they might have been more open to talk about these mental health or challenging situations, not to say mental health, but challenging situations they may not talk openly about? Is that the essence of the question?
Yes.
Dr. Brazeau or Manasa, would you, the commonality, that they had this common bond.
I see.
Is that Dr. Brazeau or?
Well,
Brian?
it's something that's in the literature as well, that for other programs that, other peer support programs that were developed in other parts of the country, that was always the premise. Is it easier to talk to somebody who's been through the same experience? And so those programs found that was the case. On a personal level, being a physician, we are trained to really be self-sufficient and to really, everybody's busy and you try to do what you can on your own before you reach out for help. I mean, that's kind of the culture. And so we just take on our shoulders, and sometimes we don't even see that we need the support because our instinct is to take care of it on our own. So that's just something that I've seen in my colleagues, and I think that what we've heard in the trainings that we did was, I'm used to doing this with patients, supporting patients, and I hadn't thought about doing it with my colleague. And also the relief to hear the ones, even in the role play, it felt good to do this. There was a surprise element even in the peers. So all of these, literature-based and experiential-based factors, really, to me, indicate that the power of peer support is really not to be ignored. And Dr. Ayala, I don't know if you want to add anything to that.
Well, I would just echo that. I think it kind of lowers the activation energy to have to engage in this. And I think having that peer support, especially, there's a ton of literature that especially physicians, the last thing to go is the clinical, piece of their lives. And so I think doing this is almost protective, or it kind of gives you that sort of additional kind of resilience. And I think having it be available is really important.
Wonderful. Thank you so much. And then I had another question that came up while, we were talking about active listening and not listening to immediately respond to fix. I think in the field of motivational interviewing, it's called the writing reflex, to be able to fix. Would you share any other maybe strategies that maybe someone can do even while they're listening to someone, just to listen and sit with them, and maybe try to address that writing reflex to fix.
I mean,
Well,
that
we-
was part, oh, I'm sorry.
No, go ahead. You're gonna go ahead.
Oh,
Jen.
that was part of the experience of the exercise that we did with the listening blocks. Where, right, the idea was, if you are aware of which block, which is your listening block, then the awareness allows you to notice it when it happens, so that you don't act on it, but you sort of pull back and remind yourself to listen.
Right, right.
And we kind of framed it as, what's your default? What do you usually go to pretty quickly? You know, because you want to, oh my God, they're in such distress. I want to, like, you're hearing this thing, and then and then your default sort of comes in and becomes that habit. So it was helping people just to kind of stop it, look at it, see it. And when I find in these kinds of doing this, I'm not sure if this is 100% correct, but I do feel sometimes when people see other people do it in a way that's strong, it helps their own insight in when they're seeing it in others. So it starts to bring and heightens that self-awareness by doing it in a way where we're not saying, no, you did that wrong. We didn't approach it that way. We let them come to their understanding. And it wasn't a wrong or a right. It's about the technique, how they used it in a way. And I think that self-awareness was just really important. And I think doing the training and doing the follow-up supporting with, not just even supporting the follow-up meetings, becomes a way for people to refine that and keep that reflective over time. So I think just even helping people to become more self-aware and then start to catch it more regularly, because we highlighted is under stress, we go to default, right?
Yes. Well, thank you so much for providing a little bit more information on that, because I know it comes up a lot, and I guess the goal was to create that awareness of when to default to problem solve, or what they call the writing reflex. So in the chat box, I shared with our participants the link to our short evaluation survey, so you can provide your feedback on today's webinar. I don't see that we have any more questions. I did see someone who also asked about the website for the slides and recordings, and that will be emailed once it becomes available.
I was wondering if anybody who's here today is likely to perhaps think about starting something like this in your setting. Maybe you could post that in chat. Are you thinking about that? Or we just maybe want to get a sense. Are you thinking about it for what group? What would be the group, the population you might think about that? It'd be nice to see in the chat. And, so yeah, for the IRTS program, that the intensive recovery treatment support program for staff in that program sounds like a nice potential model. What other, thanks Josh for that feedback. Others that today, what group might be, this might be helpful for, or are there any things about this? Medical staff members at Children's Hospital. So will any of your program materials be available to help with implementation? Yes. Chantal, you want to say something about the website?
Well, we are working on a website where we're going to post the various materials, select training materials, and how, just the benefits as well of the program and so on. So that will be on the website.
Yeah.
Soon, I hope.
Yeah, and I see, go ahead. Reno said possibly expand to other peer support programs beyond the IRTSS. Yeah, there's a whole range of peer support programs that perhaps having a model like this could be helpful for individuals doing. There's a number of people, so maybe it could be available beyond just the one program, and that would actually help with some cross-fertilization, just as we did with this. So that's a great idea, Reno. Maybe talk to Micah about that.
I think what happens with these programs is people get in touch with their humanity, and we have our role we're all human beings within that role. And these techniques are really translatable to so many roles, so many jobs, because it's all the same human need behind it. So, the role play may need to be a little bit different. You know, people may have different blocks depending on the culture that they came from in terms of training. But the basic concepts, the listening, the sharing experiences, to convey empathy, the reframing, those I believe are universal and really can be applied to many, many settings.
Well, thank you so much. Peggy, I wanted to know, do you have any other additional slides with resources that you'd like to share, perhaps? We do have feedback in the chat. This was very helpful.
Yeah, we'll have the website material. We can, just reach out on our email. I'll bring that back up again. Let me see. Hopefully I bring up the right one on the screen here. Okay, I think that, I think we have our email. Our emails will be here as well to contact us. Reach out, and if there's things that we can specifically help to think about, if you're thinking about targeting doing it, if you're thinking about a training. I have a planning document that I can share from another self-care things we did with the MHTTC, very similar to this, that could help you with some planning questions that I could share as well. And also, we've thanked everybody for your interest, and really, this is just an important, I've been decades of peer support. I've always, but to understand how it can really help in this space of healthcare providers, it's more, the time is right now very important. So we're really grateful for everybody to be here and keep, sharing these ideas, because we definitely, this is a really important time more than ever. And, having a program like this and having this be able to be expanded to help other people is just going to really help so much of our workforce. And again, help the patients and the people we serve out there in the community even more. So we appreciate everybody's interest in the topic today, and be happy to share follow up.
Peggy, there was a few more slides.
Oh yeah. Right.
We just wanted to
Yes.
to thank our funder, the Healthcare Foundation of New Jersey, and also the support that was provided by our medical schools and the University Behavioral Health Care. And then next slide, we have a central message about the importance of empathy and communicating that you're not alone, which is really at the your support. And then the final slide, speaking as well in terms of references that you may need to develop your programs. So those are the references. So they will be included in the slide so that you can look for that. The second reference by Dr. Shapiro, Peer Support for Clinicians, is one where you will have the literature I was referring to previously about that, how clinicians tend to not reach out to mental health providers, but are more open to peers.
Well, thank you so much. I want to thank our presenters for sharing with us today and for providing us with our second session in this webinar series. We do have 2 additional sessions, so we hope that you will join us there as well. In our follow-up email, I will also send the registration link for the 3rd and 4th session. Again, just want to remind everyone that this will be posted on our website, the recording and our presenter slides, and everyone will also receive a certificate of completion. So we want to, again, thank you all, and we hope you have a wonderful rest of your day.
Yeah, and the session 3 and 4 will go into some more of the competency pieces. So we'd encourage you to come back to those. The peer support competencies, yeah.
Yes, thank you so much.